Good morning, everyone. Let's start with today's topic, that is osteomyelitis. These will be the contents. Let's dive into the class today. Definition. Definition of osteomyelitis says that it is nothing but an infection of bone caused by a microorganism. The name of the microorganism which causes osteomyelitis is Staphylococcus aureus, which is commonest. There are two more microorganisms which can cause osteomyelitis. Those are Streptococcus and Pneumococcus. Coming to the types of osteomyelitis, there are two types, acute and chronic. The common sites where osteomyelitis is seen is nothing but lower end of tibia, lower end of femur or upper end of tibia. Now coming to acute osteomyelitis, the first type. Acute osteomyelitis is further classified into two types depending on the what is the mechanism of osteomyelitis. First one, primary. Second one, secondary. Primary is nothing but it is caused by a hematogenous root. The root cause, the location, the focal site of the infection is somewhere else. It has traveled via blood vessels, reached the femoral lower end or tibial upper end, that's causing osteomyelitis. Secondary is nothing but followed by the open fracture. You fall on a road wherein you get an open fracture wherein your tibia or lower end of femur is exposed to the dust. The dust can get accumulated on the bony end, causing osteomyelitis. That's nothing but followed by the open fracture or unsterilized bony operation. Now coming to why it occurs in tibia and the long bones, especially femur and tibia. Take an example of this, a knee joint, wherein we have something known as hairpin loop arrangement of the arteries and the veins. These are nothing but your medullary artery and medullary vein. This is the highly vascularized zone that is metaphysis of the long bone, as you can see in the image. Focusing on this hairpin loop arrangement of the vessels, just look at the arrangement. It's so nice to see the arrangement. We understand definitely by the diagram that there is stasis when these arteries are connecting to the vein. Thus, the stasis is present in metaphysis of the long bone. Also remember that when there is blood stasis, that is the favorable site for the microorganism to grow more, thus causing infection. There's one more point to remember regarding metaphysis, that it has poor macrophages. Keeping these all in the head, we will deal with relevant anatomy. Relevant anatomy is nothing but metaphysis of the long bone. Why it is prominently, getting infected by the microorganism that is Staphylococcus aureus, thus leading to osteomyelitis. There are four important factors. First one, it is highly vascularized. We just saw it in the last slide. Second one, blood stasis due to hairpin arrangement. I just explained you all. Third one, blood stasis is nothing but favorable site of microorganism to grow. That is nothing but bacteria to settle. The third point. Fourth one, metaphysis has poor macrophages. Thus, these all 4 points are very important for a microorganism to settle, to grow, to reproduce and form it into an osteomyelitic infection. Thus, osteomyelitis mainly infects the metaphysis of the long bone. Now coming to how osteomyelitis differs in intracapsular and extracapsular joint surfaces. First, let's learn what is the example for intracapsular and what is the example for extracapsular. Look at the diagram. This is a knee joint. I have just removed the fibula in order to understand where the capsule attaches to the tibia and femur. The second image is nothing but your hip joint. Look how where are the growth plates present in both the joint. As you can see, the growth plate is dividing epiphysis and metaphysis. The growth plate is present between epiphysis and metaphysis. Now we already learned that metaphysis is the favorable site for Staphylococcus aureus to get settled in order to cause osteomyelitis. So please remember that and look how the capsule is attached to either bones in both of the joint. So in the first joint, that is your knee joint, the capsule is attached only to the growth plate. That is, it doesn't take over on the metaphysis. It just includes the epiphysis and the joint surface area. Whereas in hip joint, the capsule also involves partly metaphysis. What did we learn till now? The accumulation of the bacteria is dominantly in metaphysis. Looking into the diagram, if we think that bacteria is getting accumulated in metaphysis, in knee joint, it has two barriers to cross and touch the other joint surface. That is, first one is your growth plate and second one is your capsule. Whereas in hip joint, it just has to cross only growth plate because metaphysis is within the capsule of the hip joint. Thus, osteomyelitic infection differs in intracapsular and extracapsular joint surfaces. In extracapsular joint surfaces, there are least chances of osteomyelitic infection to travel across the joint line reaching the other joint surface. Whereas in intracapsular, it can easily infect the other joint surface as well. This will lead to something known as pyogenic arthritis. Pyogenic is nothing but infection. I'll be dealing it in future. Okay, coming down to idiopathogenesis. We have already read idiopathogenesis. The main bacteria is Staphylococcus aureus. It can be caused by the other two bacteria, that is your Streptococcus and Pneumococcus. Usually, primary focus of infection is goes undetectable. It has traveled from blood vessel via blood vessel from some other side, getting located into the metaphyseal region of the long bone because that is very favorable to settle because of the blood stasis and gets infected, knowing as osteomyelitis. Now coming to, once it gets settled, what happens? How it travels within the bone to infect it. Look at this again, knee joint. Again, I have removed fibula just for your understanding how it occurs. Just take out the femur and patella as well. Concentrate on the tibia and its growth plate. We know that bacteria is getting settled in which part? That is metaphysis of the long bone. It has three directions to travel. Look at the arrow, how it is traveling. The first one, just concentrate on the downward, straight down arrow. That is, from metaphysis, as it is located in metaphysis, it will travel downward through the medullary canal, medullary cavity. If it travels along the medullary cavity, it can cause thrombosis of medullary veins and medullary artery because it gets stuck in the blood vessel of the medullary cavity. If it causes thrombosis, what will happen? The blood vessel is definitely cut off for the other part of the bone. So that leads to bony death. Look into the second arrow, that is obliquely downward out of the bone. So now this is known as out of cortex, which is the part which lies just next to the bone. That is nothing but subperiosteal space or periosteum. So if the bacteria travels into the periosteum, how it should travel? It should travel via Volkmann's canal. If it travels via Volkmann's canal and comes to lie next to next to the bone, that is your periosteum, it might cause pus accumulation in that part. Before pus accumulation, if it just gets settled in the periosteum, it will lead to death of periosteum. That is avascularization. That's what happened in the medullary cavity. If it travels along medullary cavity, it will cut off the blood supply, thus leading to death of bone. Same thing will happen in periosteum. If it travels to the periosteum, it will cut off the blood supply. It will lead to death of the bone. That is nothing but avascular of the bone. The term where it occurs, where it causes a vascularity to the periosteum is known as sequestrum. Once the sequestrum is formed, the dimension of this segment vary from small invisible piece to a whole diaphysis of the bone. That dimension, it is not the other part, it is the size of the bone what we are talking. Now once the sequestrum is formed, pus starts filling up. As the organism grows, pus starts filling up. Once the pus starts filling up, because of the activity of the microorganism, bone thinks that bone has to grow. So what the bone will do? It will grow extra part, which is not needed, which is not normal. Once the pus under the periosteum generates subperiosteal new bone. This process is known as periosteal reaction. Eventually, this periosteum becomes perforated, letting the pus out. This is known as abscess. Once it comes into contact with the skin, it will burst out, knowing as the term for that bursting out is known as sinus. Now coming to the third arrow, that is your obliquely upward. That is nothing but it is crossing the growth plate. It is crossing the capsule. It will reach the other joint surface, thus causing the arthritis of the other joint surface. The arthritis is infective, thus the term pyogenic arthritis. Best example, this will occur in intracapsular joints. Best example for intracapsular joint is hip and the shoulder. The same thing what I told about the subperiosteal entire process is going to be explained again. So let's look at it. Okay, first one, it will travel out of the cortex. Where it will come to? Subperiosteal space. After getting located, what will happen? How it will travel? Workman's canal. After getting located in the periosteum, what will happen? It will cut off the blood supply, leading to death of the bone. That is known as this is the first step, that is known as sequestrum. The second step. After second step, what will happen? It will what will it will do? It will form the pus because the bacteria is reproducing itself. So pus accumulation is known as your periosteal reaction. This pus accumulation will stimulate new bone growth. That is known as your periosteal reaction. After periosteal reaction, what should happen? The pus has stopped accumulating? No, because bacteria is still reproducing itself. So the pus is increasing. So the pus will pierce the periosteal bone. That is new periosteal reaction. What has happened? That is the yellow color. So it will the holes are formed in the periosteal reaction, thus leading to leakage of the pus. So the first step after leakage of the pus is known as abscess. So this is your abscess. I have not mentioned the 4 point. This is your abscess. Once it touches the skin, if the abscess grows, it will touch the skin. Skin will burst out. That is known as your sinus. That is the fifth point. Sorry, abscess is not mentioned. Abscess is the 4th point. That is the 5th point. Okay. Coming to 3 travel routes. We have already seen that. I'll just explain it again. This is your knee joint wherein the bacteria we know already it is getting located in the metaphyses. It will either travel down to the medullary cavity or it can travel out of the cortex wherein it will come to lie in the subperiosteal space traveling via Volkmann's canal, or it can also travel to the other joint surface which is commonly seen in intracapsular joints such as hip and shoulder. Now coming to diagnosis of osteomyelitic case. The first one is presenting complaint. When the patient walks to the clinic, what are the complaints which is presenting? The first one is acute onset of pain, swelling in the bone end. Acute onset of pain on palpation, that is your tenderness and swelling of the bone end, is usually localized in acute osteomyelitis to the region of metaphysis of the long bone. It is never localized to the joint line in acute osteomyelitis I'm talking about. Systemic features of the infection is nothing but your fever. Coming to the second point, this was your presenting complaint, how the patient presents himself. Second one, examination. The patient is usually febrile. That's what we learned in, because it is infection, definitely the patient will be febrile. Second one, dehydration. And also remember, dehydration, febrile is along with so many times is along with inflammation, because inflammation is so many times present due to infection. So any infection, what are the 2 signs to remember? Febrility and dehydration. Along with comes the walking hand. The best friend of infection is nothing but your inflammation. That is 5 signs of inflammation are definitely seen in acute osteomyelitis on examination. Coming to investigation. There are 3 main types of investigation: blood, X-ray and bony scan. Blood. First one, ESR is definitely elevated because it is an infective case. Second one, as the chronicity of acute osteomyelitis reaches, sometimes causative organism is also seen in blood culture. Coming to the X-ray, we already saw it in the previous slides that periosteal reaction is nothing but extra bony growth, the new bony growth in subperiosteal space due to pus accumulation. That is nothing but your periosteal reaction. So definitely a bone is definitely visible on the X-ray. This this periosteal reaction takes place at around 7 to 10 days after the onset of infection, that is acute osteomyelitis. After your process of acute osteomyelitis starts, it will take 7 to 10 days for periosteal reaction to happen and to see it on the X-ray. So that is what is the importance of X-ray. Before that, you can also diagnose whether it's osteomyelitis or not via bone scan. Now, bone scan is nothing but using technetium 99, which may show increased uptake by the bone in the metaphysis due to the presence of organism. This is nothing but your technetium 99 bone scan. This is much more positive before the changes appear on the X-ray. Definitely, first when you see a patient of acute osteomyelitis, please opt for technetium 99 bone scan rather than opting for X-ray if it is very acute. Okay, coming to the differential diagnosis. First one, acute septic arthritis. I have been repeatedly telling that in acute osteomyelitis, where is the tenderness and swelling? In the metaphyseal region. Whereas in septic arthritis, it is a infective arthritis only, but the tenderness is located to the joint line. Second one, acute rheumatoid arthritis. We have all, I'll be putting up the video on rheumatoid arthritis, but for just now, remember that rheumatoid arthritis has some Jones criteria, a diagnostic criteria for rheumatoid arthritis, which includes of 5 major and I think 3 minor signs. So these should be present to confirm a patient to have rheumatoid arthritis, some of which are polyarthritis, distal finger distal finger affected, and it is usually along with the, let's consider only two, that is polyarthritis and distal finger infected. Now in osteomyelitis, polyarthritis is absent and distal fingers are not infected, whereas we have already seen that is metaphysis of the long bone. Also, it is infective, and RA is its Jones criteria doesn't have any infection in it. Hence, these are the differential diagnosis of RA. But the fleeting character of joint pain and elevated ASLO titrate is seen in RA. Whereas in osteomyelitis, it is the blood culture which can give us the causative organism and elevated ESR. That's it. Now coming to scurvy. Scurvy is, we already know it is caused by vitamin C deficiency, whereas in osteomyelitis, there is no deficiency as such, it is just caused by the causative organism. Now coming to the differential characters. Scurvy, it is known to have hematomas are present rather than your periosteal reaction, which is commonly seen in acute osteomyelitis. Also, scurvy doesn't include fever, pain, and tenderness of the joints, whereas osteomyelitis does include that. Last one, acute poliomyelitis. Polio is restricted to the muscle pathology and osteomyelitis is restricted to the bone pathology, though both are caused by the infection only. Coming to treatment. Treatment is divided into two parts, that is within 48 hours, after the 48 hours, because the symptoms vary and the reaction of the organism, the reaction of the body due to organism presence in the metaphysis of the long bones varies. So within 48 hours, the differential character between within 48 hours and after 48 hours is the pus accumulation. Within 48 hours, there is no pus generated or it is very little. And after 48 hours, definitely you should take it grantedly that the pus is accumulated already. So if the child is got to the hospital within 48 hours, pus is not formed, halt the inflammatory reaction, also start with antibiotics. Talking about antibiotics, there are two types of antibiotics combination given depending on the age of the child. If the age of the child is less than 4 months of age, the combination of ceftriaxone and vancomycin is appropriate, whereas if the child is older, combination of ceftriaxone and cloxacillin is given. After starting with the antibiotics, please advise rest to the patient and splinting of the limb should be done, because once you tell a patient to rest, the patient might maintain the limb in a weird manner, thus leading to contracture and deformity, which is again bad for our bony health. Thus, splinting the limb in the position of ease and also in the position of biomechanical optimal length of the muscles is done. Rehydration should be started because dehydration was the one of the presenting complaints, and on examination it was seen of the patient related acute osteomyelitic condition. 4-hourly temperature and pulses is recorded because to have a check on the inflammatory process. Also, after 6 to 8 week, mobilization of the patient is started. That is nothing but your weight bearing. Coming to if child is brought after 48 hours. Grantedly consider the pus is accumulated already. I have told you what is the difference between within 48 hours and after 48 hours. So depending on the pus is accumulated, nothing can be done except surgery. Surgical exploration and drainage of the pus is the mainline therapy for the second part of the treatment. Make a drill hole on the bone. If the pus wells up in the drill hole, enlarge the hole till the free drainage is obtained. Complications, the last part of acute osteomyelitis. There are two types of complications, general and local. General, usually septicemia and pyemia is seen in the early stage. It is rarely seen actually. Either complications, if left untreated, these complications are definitely proving fatal. Coming to the local complications, first one, chronic osteomyelitis. Anything which is left untreated, which is left delayed for the therapy, will definitely lead to its chronicity. Acute osteomyelitis will progress definitely if left untreated to the chronicity, known as chronic osteomyelitis. Second point, acute pyogenic arthritis. If the joint infected is intracapsular, definitely if the metaphysis is intracapsular, definitely the route of traveling is also not only medullary cavity out of cortex, it is also to the other joint surface, thus leading to degeneration of the other joint surface due to microorganism known as acute pyogenic arthritis. Now coming to the third point, pathological fracture. Wherever the infection is occurring in whichever bone of the entire human body, the bone becomes weak. On loading of that bone, after that particular time, the bone will undergo fracture. That is known as pathological fracture. Coming to the fourth point, growth plate disturbance. It may be damaged, leading to complete or partial cessation of growth. This may give rise to shortening, lengthening, or deformity of the limb. Thank you. This was the lecture on acute osteomyelitis. Let's meet you all on the lecture of chronic osteomyelitis.